بسم الله الرحمن الرحيم. محاضرتنا النهارده Symptomatology of Ear Disease. أنا اسمي محمد قطب، أستاذ أنف وأذن. Symptoms of the ear. What are the symptoms? Symptoms are bad experience felt by the patients due to change in anatomy and or physiology. The symptoms is said by the patient after you take the personal history. Symptoms of the ear may be one of the following. Number one, cosmetic problem. Cosmetic problem, of course, will be in the auricular disease. The auricle may be large, protruding, smaller, or whatever. So auricular disease usually manifested by cosmosis, and the other cosmetic problem is the facial nerve palsy. The second symptoms is pain. Of course, pain may be produced by tumors, trauma, or inflammation of the ear. All tumors, inflammation, and the tumor of the ear can be present by pain, except problem in the inner ear, because the inner ear has no sensory nerve supply. Chronic suppurative media is an inflammation of the middle ear which is not presenting by pain. And the third condition that pain may not present is the incidence of cutting or disease of the sensory nerves of the ear. You should know what are the sensory nerves of the ear to know the exact origin of pain. Here is the great auricular nerve. Here is the behind the lesser occipital. The posterior part of the external canal is the sensory supplied by the vagus. The anterior part of the external auditory canal and the drum are supplied by the auriculotemporal nerve. And here is the middle ear, especially in the promontory, are supplied by the Jacobson's plexus, which is derived from the glossopharyngeal nerve. So this is the sensory supply. No sensory supply of the inner ear. If the patient coming to you complaining of pain and you examine the ear and you didn't find any cause, inflammation, tumors, or trauma, and still the patient complaining of the ear, this pain may be referred from other pathologies that share the nerve supply with the ear. For example, cervical problem can radiate pain to the ear through the great auricular and lesser occipital. Sensory problem or inflammations of the oral cavity and hemineck and hemiface can refer the pain through the auriculotemporal nerve or the trigeminal nerve. Sensory problem or inflammation of the larynx and painful condition of the larynx can radiate pain to this part, which is supplied by the vagus. And lastly, the painful condition of the oral cavity and pharynx can refer its pain to this region through the Jacobson's nerve. This is the second symptoms, which is pain. The third symptoms is the discharge. Discharge coming from the ear. Usually the normal discharge which can come from the ear is the wax. Any other discharge coming from the ear is abnormal discharge. So discharge may be purulent discharge or mucopurulent, may be bloody discharge, may be watery discharge, may be pulsating, may be offensive. So if you look to know the type of the discharge, look to the type of epithelium. This epithelium is stratified squamous keratinized epithelium. So here there is no goblet cell. So if you find a mucopurulent discharge in the external canal, usually it's almost always coming from the middle ear, because the middle ear epithelium Here is the middle ear, is the middle part with the mesotympanum and eustachian tube. Nasopharynx are supplied by are covered by pseudo-stratified columnar ciliated epithelium. So presence of mucus in the discharge coming from the ear means that there is a perforation and this discharge coming from the middle ear. Purulent discharge may come from the external canal or from this zone, which is the attic part of the ear, which is lined by stratified single columnar or cubical cell not containing a goblet cells. So mucopurulent discharge may come from here, may come from here. Mucopurulent discharge may come from the middle ear, but purulent may come from the external canal or the attic. Water discharge means CSF. So how CSF come through this ear? May come through this pathway, which is trauma to the skull base, leaving a fracture here, and the CSF come from the canal. This is a CSF rhinorrhea. If the drum is intact and the fracture is here, the CSF will fill the middle ear, may come through the eustachian tube and then go to the nasopharynx, go to the nose, or drip in the esophagus. So this is the pathway of watery discharge coming from the CSF, either this pathway or it may come from the roof here and come through the external canal to present through the ear. Discharge may be bloody discharge. Blood discharge usually come from trauma to the external ear. Well, of course, the history will be evident. Blood discharge may come from something called bullous meningitis, which is influenza viral infection producing a bulla on the drum. It may rupture and present with blood. Blood discharge may come from vascular tumor or aneurysms from the middle ear. This is blood discharge. Discharge may be offensive. Offensive discharge means that there is anaerobic infection or bone necrosis or tissue necrosis. Offensive discharge may be due to cholesteatoma. This is a commonest cause. Cholesteatoma here. There is associated bone necrosis, anaerobic infection, usually associated with small perforation in this attic part of the drum. Offensive discharge may come from myiasis, which means presence of dead bodies of flies or larvae on top of infection here, myiasis. Malignant tumor with necrosis may present with bad or offensive discharge. Discharge may be pulsating discharge. Pulsating discharge, usually pulsating discharge is due to small or high perforation here. Small or high perforation is inadequate to drain the pus, so there is a pulsation. Pulsating discharge may be due to acute infection on top of chronic supraspinatus media. Pulsating discharge may come from pulsating tumors or aneurysm in the middle. This is the third symptoms. Hearing problem is divided into diminution of hearing or hyperacusis. This is it. Sometimes we put the tinnitus as a hearing problem, sometimes we put it as a separate symptoms. So diminution of hearing, there is three types of diminution. If the problem is in this part, from the external canal to the middle ear, it's called the conductive hearing problem. If the condition is in this part of the cochlea, it's called sensory hearing problem. And if the condition it is in this part, it's called retrocochlear problem or neural problem. So there is usually the patient with conductive hearing loss coming to you with a low, he complains to you with a low voice because he hears his own voice loud. This is called tophony. Patient with sensory neural hearing loss, with sensory and neural hearing loss are different. Patient with sensory loss or problem in this area usually talk to you and is gazing to you. He is trying to read your lips to understand what you see, what you say. Patient with retrocochlear or neural pathology, the problem is usually in the discrimination. He said you, I hear better, but the discrimination is bad. So this is the three types of hearing. On contrary, hyperacusis means that the normal voice is the patient comes said that normal sound is irritant to me in this ear. And hyperacusis usually due to problem in the facial nerve or problem in the stapedius muscle, making the patient feel the sound with uneasiness. Sometimes the patient coming to you complaining that he lost the function of hearing. So is hearing, what is the function of hearing? Hearing is important for communication, for language development, for learning, and for protection. Sometimes if the patient is a young age, he is not complaining of diminution of hearing, but the mother coming to you complaining that this patient is retarded in school progression, retarded in language. So retardation in language and school progression may be a manifestation of diminished hearing, especially in children. The fifth symptom may be tinnitus. Of course, tinnitus means abnormal sound felt by the patient or sometimes heard by the others. If the others hear this tinnitus, it's called objective tinnitus. If the only the patient feels this odor, it is called subjective tinnitus. So what is the causes? The tinnitus is a problem in the brain. So the brain center hears abnormal sound that is not usually present, and this is the what we call subjective tinnitus. Subjective tinnitus may be caused by any diseases of the ear. Any disease of the ear can cause tinnitus. So tinnitus may be present with perforations, may be present with or causes of conductive hearing problem, may be associated with sensory problem or retrocochlear problem. The problem is tinnitus may be caused by systemic diseases, and its reverse may cause tinnitus. Hypertension cause tinnitus, hypotension cause tinnitus, hyperthyroidism can cause tinnitus, and hypothyroidism can cause tinnitus. So if you didn't find any cause of the ear, you should look for a systemic cause of the tinnitus, and sometimes tinnitus is idiopathic. You look for a cause of tinnitus and you didn't find. This is called idiopathic tinnitus. The last symptoms is vertigo. Vertigo means rotation of the patient or its surroundings. The patient said, I am rotating, or the environment is rotating. So usually the vertigo is due to problem in the semicircular canal or in the vestibule, which is the areas in the ear responsible for direction of your head position to the brain. So if the problem in the canal or in the vestibule, it will cause vertigo. Of course, the vertigo may be associated with diminution of hearing if the condition of the inner ear is associated with cochlear problem, and sometimes the vertigo is not associated with hearing problem if the condition is localized to the sensory component responsible only for the balance. Of course, vertigo can be caused by other causes systemically like tinnitus, but usually in the vertigo of ear etiology there is three main causes. First is the benign paroxysmal positional vertigo, second is vestibular neuritis, and the third is Meniere's disease. And these three main causes of vertigo can be diagnosed on the level of clinical basis. So the patient with benign paroxysmal positional vertigo will come to you, say that I have vertigo lasting 4 seconds only in specific position, and it is not associated with any problem in hearing or tinnitus. This is a benign paroxysmal positional vertigo. Vestibular neuritis, on contrary, the patient coming to you saying that I have vertigo for days, not related to any position of the head and not associated with hearing problem. This is different problem. And the lastly, the Meniere's disease, the patient said to you that vertigo lasting for minutes, not for seconds like benign paroxysmal positional vertigo, and not for days like vestibular neuritis, and the vertigo is associated with hearing problem like tinnitus or diminution of hearing in the affected ear. So this is the main three causes of vertigo, and thank you.